Beneficence, non-malfeasance, autonomy, and justice are the four main principles of medical ethics. Stay tuned while we flesh this out. Hey, this is Brad Block, host of The Physician's Guide to Doctoring. This is a personal and professional development podcast for physicians where we have experts on the show that try to teach us everything we should have been learning while we were memorizing Krebs cycle. Welcome back to the podcast. On today's show, we have someone that I've been following online for a long time, so I'm super excited to have on the show today. Dr. Stephen Bradley is an anesthesiologist, critical care physician, Navy veteran, and medical ethicist. That last part is why he's on the show today, with a passion for mentorship and increasing diversity in the healthcare workforce. As an assistant member at the Moffitt Cancer Center and an assistant professor at the USF Morsani School of Medicine, he combines his clinical practice with educating medical students and resident physicians. You can see he's got that nice mic in front of him because he is a podcaster himself. He's got a fantastic podcast that you definitely need to check out. He's the host and creator of the Black Doctors podcast. He interviews minority professionals in a variety of career paths to provide encouragement and motivation for listeners. Dr. Bradley, thanks for being on the show.
Dr. Block, thank you for the invitation. I've listened to some of your episodes. They've been quite helpful in the past. One about creating PowerPoints. Very mundane, but very helpful.
Yes. Thank you. I appreciate it. Actually, that one changed the way so sometimes I give talk to like residents or medical students, and it changed the way that I do that. And actually, I don't really use my PowerPoint anymore because of that. Well, thank you. I appreciate the compliment. So let's talk ethics. So I've heard you talk about it on your show, and there is a framework here for thinking about ethical decisions. So I think that's a great place to start.
Absolutely. So when we're faced, especially in the healthcare setting, I'll speak mostly as people engaged in practicing as physicians, from residents on to attendings. There is a framework for actually tackling challenging ethical decision-making when it comes to patients. That's more prescribed. It involves dealing with all the key stakeholders, looking at the institutional policies and practices, breaking down those classic four tenets of medical ethics: autonomy, beneficence, non-maleficence, and justice. We could start with the textbook definitions, the philosophies behind ethics and bioethics and Kantian styles and all those big words and big concepts. And these guidelines definitely exist, but I prefer to start kind of from an introspective. I'm naive enough to think that we are inherently ethical. Those of us that went into medicine, to help people is on most of our personal statements. And at least at some point in our lives, we were fairly ethical. Along the way, our decision-making and ethics have changed and been shaped by our worldview and our different environments throughout our training. But within the realm of medicine, we have our medical ethics code from the American Medical Association, just like nursing has a code of ethics, just like banking has a different code of ethics. And when it comes to patients, I like to maybe start internally, go with your gut instinct for what's best for the patient, tap into some of that altruism, a little bit of that paternalism, which is a dirty word a lot of times these days in medicine, and then center the patient, their needs, their wants, and concerns. After you've done that, you can do some introspection. Did the choice that you made initially, did that differ from what the patient wanted? If so, how? Was there a knowledge barrier, something you didn't know about the patient or their priorities? Was there a cultural gap? Was there bias? And then in future encounters, you can kind of compare what you've learned from previous encounters and use that to interact with patients in the future. That's how I like to look at it. Each patient, you're just learning so much about their culture, what's important to them, and you're using that in addition to things that we've learned in medical school about medical ethics.
I apologize. I'm going to need to divert from my original list of questions because the way you just described that made me think of like a particular situation that we find ourselves in, unfortunately, all too often. And that's in the realm of misinformation, right? Where the patient believes this bit of misinformation and they believe it to be true. Our goal is to find out what their health goals are, not what your goals are for them, but rather what their own health goals are. And let's say that misinformation has become a barrier between them and achieving their health goals. Does trying to persuade or navigate them around that misinformation, is that unethical? Or do we just allow them to continue having that belief system?
That's tough. There was a question that we will probably get to at the end, but it kind of coincides with this. It's very difficult when people have these deep seated beliefs. You'll see whether it's misinformation, whether it's religious preferences and practices that interfere with our traditional Western practice of medicine or what we believe to be is the right thing to do. I had a patient who had a really bad oral cancer. Patient was not decisional. Their spouse and decision maker had a whole list of holistic treatments, wheatgrass shots, and all this other stuff, and was not going to pick up this patient's medication, was going to take them home. And this patient was honestly very, very advanced cancer. I was just a resident at the time, but I was faced with the dilemma. Do I try to sit in this room for an hour and debate with this decision maker why it was a crazy, crazy concept and that their spouse was going to die if they went down this course, but they were going to die anyways from the cancer. And sometimes you have to pick and choose those battles of if I lay out all the facts and use my best reasoning, will this honestly make a difference? And will that patient really appreciate me pushing them into this box of traditional medicine? Sometimes their belief system, it wins out. I try to avoid conflicts of interest or patients that the patient clearly kind of has a different decision. They want the treatment and they're being taken advantage of, or they're being coerced into something by that family member. But if I'm able to communicate with the patient and everybody's on board, then I'm often hard pressed to convince them into what I think and what most clinicians would think is the right thing to do.
Agreed, agreed. If they're really dug in that belief that isn't changing, because sometimes people are really, it's part of their identity. And in a doctor's appointment, you're not gonna be able to move that. A lot of times you mentioned these ethical decisions are, you're involving other members of the team. There might be like a way to deliberate on what the right course of action should be. Before we get into that deep dive, what about like the mundane day-to-day stuff? Are we making ethical decisions for our patients throughout the day without even realizing it?
Absolutely. And I'll kind of rephrase that to say we often impose our ethics and moral code on our patients. What we think is right in terms of autonomy, justice, non maleficence, beneficence. That's our perspective. And how we do that may or may not coincide with what that patient's preferences are, that patient's own autonomy. Again, people are empowered, they have the autonomy to make bad decisions about their healthcare. And so it's always a balance of push and pull between using the things that we were privileged to learn that can be used to help people versus, overruling their autonomy. If we provided that information, we've had a thorough informed consent conversation about the risk, benefits, and alternatives. Documentation, that's a whole other part of this of covering your butt, the defensive medicine piece. But we often do enforce our bias into these scenarios. But again, our bias also comes with a significant amount of medical training.
It's come up on my show a couple times before where I asked the question that is persuasion, using persuasive techniques ethical? But I'd be interested to get an ethicist's because usually the people that I'm asking are those that are skilled in persuasion. And they're like, their answer has really been, listen, you're the one with the wealth of knowledge. And as long as you align yourself with their health goals, kind of like what I was getting at before, like, yes, you can use persuasive techniques and that's different from manipulating them, right? So I'd be interested to know what your perspective is it ethical to try and persuade your patients?
Yeah. The verbiage definitely matters. There's coercion, there's manipulation. Those have kind of a negative connotation. And oftentimes you're distorting something to try to almost trick or use some leverage to force somebody into a certain path. Whereas with persuasion, when you're in a hotly contested debate, you're trying to persuade that other person of your viewpoint. And oftentimes that is what we're doing with patients. And I use this sparingly. Usually it's a conversation where you understand what their values are, they understand what you're saying, and it's a friendly conversation. Sometimes they come with data from, maybe a different institution, and they do things differently at the hospital up the street, and you're going to persuade them that, hey, the data that I have shows that this surgery is better, has better outcomes. I'm not saying that they're wrong. It's a different way to practice. And I think persuasion can be used, especially when it's something that you very much believe is the right course of action, and you're couching that in how well you understand that patient's goals and desires. They want this outcome, and they're only going to get it if they go down this pathway. Then it may take some persuasion, whether that be showing additional evidence, having a long, polite, thoughtful, considerate conversation as well. But oftentimes, you need to continually gauge that patient, and you can see, usually, if you're a decent communicator, when they start to feel that frustration or that they're not being heard or understood, and now they start to feel pressured into making a decision. And that's where you kind of start reeling it in. I try not to pressure patients into decisions, even when I think it's the one that they should make.
You're saying read the room, read the
Read the
room. So
room.
it's okay to use persuasion, but read the room. And if the temperature of the room is changing, then it's time to, kind of lay down your weapons and just go with what's been determined so far. Yeah.
Yeah.
Yeah. You had said before that as we're making our own decisions throughout the day, right? These just day-to-day, more mundane decisions, we are, or maybe imposing our own worldview and biases and ethical judgment on our decisions. How do we know when we're doing that, right? How do we know when we are imposing our values on the patient rather than using theirs?
Yeah, I think this happens not frequently because most of medicine, people come to the hospital. I'm an anesthesiologist. They show up for their surgery. They've already consented. They drove to the hospital. They've spoken with their surgeons in clinic days, weeks before. You're an otolaryngologist by training and practice. So they've chatted with you. They're here. They're not here to see me from
Yes.
anesthesia. I'm still going to go through a whole consent process. So there's not much of my values to impose. As an ethicist, I've really worked to remove myself from the conversation. But what I often see, or how I often see this play out, is for residents or medical students, mostly residents, you're in the ICU, the patient's not doing well, they're not going to make it. And they go in there, have a long family meeting, and come back and say, I got them to go comfort care, or I got them to go DNR, DNI. I've really tried, and I encourage people to not go into these conversations with an ulterior motive, because that's
Yeah.
biased and clouded your judgment and that conversation. Your goal is to go in, explain what the outcome of each path looks like. There's you could scare them, oh, we're going to do chest compressions to crack your ribs. It's a little coercive, but understanding what does grandma really want with her life or quality of life. She was out gardening. She'll never garden again. Is she okay with living in a home? Is she okay living, breathing with the machine? And if they come down to it and say, yeah, she wouldn't want that, then that's one alternative. Or they could say, do everything. And as long as, you're not bringing harm to the patient, which there are other avenues to go down if things are being done that are unjust. Those are very difficult when you have to involve the court systems or medical legal, and those are very long processes. But understanding that I'm not trying to push you into becoming DNR, DNI. I just want you to understand what these concepts mean and how this will impact the rest of you or your loved one's life.
I think the way that you phrased it, I got them to,
Mm,
really shows the perspective the physician is coming from, right? As opposed to they have decided or we have decided, right? And ultimately, I think it's they have decided. But
yeah,
like, I'm going to go check with the family and see if this is still consistent with their wishes and desires. Okay, we've had this conversation. They have decided, not I got them to. That's,
yeah,
as you were saying, more like manipulative and coercion rather than, although honestly, there is some degree of semantics there between persuasion
absolutely.
and coercion and manipulation. It's just, whatever word we decide suits us best in the moment. There are subtle differences, but yeah, I think when you approach it from the perspective of, let's see, given this new information, if they want to change the course of action rather than let's see if we can get them to.
Yeah, because especially during training, there's talk about the hidden curriculum and what are we actually teaching people. And, you rotate through ICU as a resident, intern year, if you're internal medicine, you do a couple ICU rotations, and you have that patient that's chronic and not going anywhere. and everybody's done everything, and you're all exhausted, and the team is fatigued. And I say that, I got them. It's almost like you've been victorious.
Yeah.
You've solved the problem that we've all had. And unfortunately, that can kind of
Yes.
creep in to medical training. We're burnt out in residency. It's tough times, but I try to be very specific with those semantics. Yeah.
Yeah, I'm 12 years out, 12 and a half years out. I don't work in a residency program. Like, I'm very private practice. So those days are far behind me. It seemed like it would never end. And now it's turning into a bit of a distant memory. And the sleep deprivation really propagates that forgetting. It really does. Those memories are not hard and fast. Is there like an example of an interesting, try to change the names and dates and places to keep their anonymity, like they say at the beginning of NCIS or whatever shows, so they don't represent a real situation, but like an interesting medical ethical situation you've encountered?
Yeah, the more interesting it gets, the more specific. They get very specific very quickly, but they're
Yeah.
always difficult when there's a fetus involved. This often results in multiple options for medical decision makers. Is it the parturient? Is it the patient's biological father? I'm sure there's actually more progressive terminology that I should use. I do apologize. The parturient, a minor. Can you terminate pregnancies in the location that this situation is going on? What if they're brain dead or in a persistent vegetative state, rather, and still have a viable fetus? Do you use them as an incubator? Who makes that decision? And then there's the medical component.
The answer is the state senate.
Yeah,
That's who
yeah.
makes that decision, right? It's
Unfortunately, I
not.
don't know.
Yeah.
Yeah, it's hard to keep track because it's changing faster and faster and in the wrong direction.
It's just nuts because they have no idea and they don't
Right.
want to have any idea. They don't. They just want to make their decisions and put their heads in the sand, and the consequences can be what the consequences are as long as they got their
Yeah.
win. They got their
The
check mark.
IVF,
Yeah.
and I can't even wrap my head around the ethical implications of the IVF decisions recently out of Alabama because there's
Yeah.
so many permutations of how that affects.
We actually did an episode a while ago on IVF after the decision of the Supreme Court, right? Where it really that changed everything.
Yeah.
And this was obstetrician who she's a fertility specialist. She had no interest in politics, no interest whatsoever. And they were about to change the law such that IVF would not be possible in their state anymore. And it just catapulted her into
Yeah.
this like situation that she never saw herself. She embraced it and she really did a lot of heavy lifting and got a lot done in her state. So yeah, so the rabbit hole of medical ethics around any like viable, non-viable fetus pregnancy. Yes, okay. Yes. I mean, I was hoping to get something a little more quirky, but
Let's see. So
okay.
one of the quirky things that has come up in different cases is depending on the state, if a parturient is determined to be brain dead, but they want it to be an organ donor, for example, different organ procurement networks will not procure organs while there's a viable fetus. Or
So we're
they
just
want to be
gonna
an
we're,
organ donor, so you have to terminate the pregnancy and
yeah,
then harvest organs, which is just a very bizarre thing that's
yeah.
come up a couple of times, always out of the blue, but depends on the state, depends on the organ procurement network. You have to have family members that are adamant about their loved one fulfilling their wish to be an organ donor to go through this very extensive process.
My heart goes out to anyone in that situation and anyone that has to help make those decisions to find a way to not take that stuff home. Which segues into our next question about dark humor, because it's something that I've spoken about on the show. We had a guest a long time ago, the founder of The Onion, that talked to us about how to be funny. And actually, I'm going to be doing an episode in a little bit with a stand-up comedian
Oh,
on
wow.
how to be funny with your patients, right? But you did an interesting take on that, and that is the ethics of dark humor. We use it to get by. I remember this great scene from Scrubs where he talks about, using their humor to just get by day to day. I loved your take on it. So like, when is it okay and when is it not? Let's answer that question.
I try to be very cognizant of the context within which I'm sharing dark humor and who else is going to be privy to it. If you go on social media, there's a ton of meme pages, there's Twitter, and I don't want to be a wet blanket, but my thought is patients see all of this. I can't remember what inspired me to make that ethical podcast episode about dark humor, but one of the more recent stories, it's not even recent now, but there was a group of labor and delivery nurses, and the viral video was like, share your ick. And their ick was, my ick is when mothers have very extensive birthing plans. I guess L&D is kind of the theme, second theme of this episode, I guess.
ENT and an anesthesiologist that we're talking about, L&D.
They would share, it's their ick because you have these very extensive birthing plans and patients' wishes can get very complicated. It's understandable as somebody that works on labor and delivery and knows epidurals is like, yeah, sometimes, people ask for a lot. But in addition to all the labor and delivery nurses and OB residents and physicians that are seeing your TikTok video, there's a group of parturients, laboring or soon to be laboring mothers. And they know now that labor and delivery nurses kind of roll their eyes when you come in with your birth plan or whatever the other icks were. So understand that, you make things for a specific audience. I make this for my friends in healthcare. The entire world gets to see that as well. And oftentimes they're probably going to have more interaction with healthcare workers on social media than in their real life when they kind of go to the hospital because they need something done. They see more physicians dancing on TikTok than that rare moment that they show up to the ER. And now the back of their head is like, yeah, last time I saw an ER, people were dancing. And that, that's not even dark humor, but I think we have to be very cognizant of what we put out, how it can be interpreted from a patient's perspective. And then if you're attaching your face to it, that obviously has implications for your career. It's one thing if it's a faceless meme page, shout out Anesthesia God or Code Blue memes, all those guys. But, when you're attaching your face to it, that's going to have an impact on the patients that you see. It's going to be representative of, the complexion of your skin. As a Black physician, as a white physician, was your joke borderline? Was it slightly xenophobic? Well, it's going to be exponentially worse as it's interpreted by different communities, regardless of your intent. So I try to be very PC, and I'm always looking at my social media too. I'm like, was that okay? I try to be very non-problematic.
It's hard. You try to be non-problematic, but humor often lives at the edges. And so
Yeah.
making it, still being able to push the envelope there and yet have nobody be offended by it, that's a really tough thing to straddle. Something that the guy that founded The Onion said that I love, I'll repeat it like ad nauseum. The goal of humor is to comfort the afflicted and afflict the comfortable. If you are afflicting the comfortable, you're fine. And, Glaucom Flecken, Will Flannery is like the king of that. So health insurance companies, administrators, he pokes fun at the different types of physicians that are out there, or different specialties and what our stereotypes are, but you never see him punch down. You never see him, make fun of patients. There are people that get these huge followings. I think there's like an ER nurse who he makes like tons of TikToks and they're super popular but oftentimes he's punching down on the patients. It's not okay. It's not okay.
That reminded me because Dilaudid, right? That's a punchline for a bunch of jokes. The patient that only wants, the medication by the letter, starts with letter D, vitamin Dilaudid. And we all get that in healthcare. But there is a subset of patients that are dealing with chronic pain or sickle cell. And now they have the entire medical community laughing about them for asking for the one drug that actually treats their pain.
Yeah.
And it just breaks my heart when you frame it that way. Again, I don't want to be a wet blanket, but it's like, could we stop with the Dilaudid jokes? We get it.
It's easy to make those jokes. It's easy. It's hard to make the other jokes. And I think oftentimes that's what it comes down to is it's easy. And so we do it. Do you have any parting words on medical ethics, on just to reiterate those 4 pillars of medical ethics and how we can try and use them throughout our day-to-day decision making?
Run through them when you're in an ethical dilemma, or even as you're dealing with patients. Autonomy. Are you empowering that patient to make decisions about their healthcare? Are you providing information to help them make an informed decision? When it comes to beneficence, that's kind of the easiest one to get right. We always want to do what's best for patients. We want them to get better. Sometimes when we want them to get better a specific way, even if it's evidence-based, that may not be the right way for that patient. There may be extenuating circumstances to where that thing we want to do that provides beneficence and healing, it may not be the right time for that patient. They may need to go take care of something at home and leave AMA and go feed their cat because that's the most important thing in the world to them. And then maybe they'll come back, maybe they won't, but you explain the risk benefits and you try to do what's best for them. When it comes to non-maleficence, do no harm. How many different ways can we cause harm to patients, whether it's from fatigue, and we talk about duty hours, and that's a whole huge issue in medicine. But are we doing harm by the bias that we're interjecting into our interactions with patients? Are we causing harm by not listening to other members of the healthcare team? When the nurses have a concern or other members of the healthcare team, are we causing harm to our patients by not listening to them and validating their concerns? Justice, that comes up in a huge way in how we distribute resources. How do you distribute your time? Do you spend your time with mostly patients that look like you, that smell good, that are fairly clean? Are you neglecting the patients that don't smell so good and aren't as clean, or you don't understand them? And it's tough because we naturally gravitate to people that look like ourselves and that are pleasant. What grinds my gears is like, oh, this patient, very nice lady. He's a very nice man. It's like, whoa, we're preconditioning. We're all this preconditioning in medicine. They're a nice person. So what does that mean? They deserve more time or more care? What if there was this grumpy old 78-year-old man? But breaking it down based on the 4 principles of ethics, and they're really, with all the time we have as physicians and clinicians, just having time to think about what that really means in different situations, in different patient encounters, I think can really help us move the needle and be prepared for those ethical dilemmas that just pop up out of the blue. You don't walk into work expecting some ethical conundrum. They always happen when you least expect them. But spend some time thinking about it, and you can always reach out to, usually there's an ethics committee at your hospital, around on social media for ethical questions, should you have any, and we can all work together to do what's best for our patients.
Is that an invitation for free consultations right there?
Absolutely. I actually have a website, stephenbradleymd.com. Now, it is very dated, and I haven't updated it in probably like 3 or 4 years, but I think there is a little button where you can send me ethical questions, and it'll go to my email. And maybe I'll update that at some point.
Wow, that's fantastic. And that was a perfect segue, too, because we were about to close out the episode where I say, hey, where can people find you online? So there it is, stephenbradleymd.com. And then also don't forget to check them out on the Black Doctors podcast, available where all podcasts are available, wherever you're listening to this one right now. That's fantastic. Super interesting stuff. Great way to frame and think about these decisions that either we have to wrestle with for a long time, or just the split second mundane decisions we make all the time. So Stephen Bradley, Dr. Stephen Bradley, thank you so much for your time and your expertise.
Thanks for having me.
Thanks for listening. So please share it, or like it, or comment on a social media post, or write us a 5-star review. Thank us again for listening to The Physician's Guide to Doctoring.